The nice thing about thyroid cancer, especially papillary thyroid cancer, is that they have what we call targetable mutations that exist. Right now, everyone knows about BRAF as being the most common mutation and something that's very targetable with BRAF inhibitors. And while none of those BRAF inhibitors are FDA approved, they are companion approved and have been shown in phase 2 studies to be very active in thyroid cancer. But what's getting more exciting is that some of these less common mutations also are able to be targeted, and we're seeing great responses in clinical studies. There is the LOXO-292 drug. They presented at ASCO this past summer. It showed that in RET fusion papillary thyroid cancers, an extremely high response rate in a drug that's extremely well tolerated. And we've seen like some great results, with that drug. But there's other drugs that specifically target RET that are very well tolerated and are going to have the exact same activity. The other thing would be NTRK fusion genes. So this is something that's also seen in papillary thyroid cancer. In any patient that does not have a BRAF, RAS, or RET fusion gene, if that's papillary, you should actually check for an NTRK fusion gene. And we also see excellent responses with these NTRK inhibitors as well. And we expect that these NTRK inhibitors will eventually be approved for any tumor that has NTRK fusion gene. So this is another perfect thing for us to target. The other thing that we've known that exists is that, and this you'll see a lot of times in Hürthle cell, is a TSC2 or TSC1 mutation. Dana-Farber in a study with everolimus shown an anaplastic thyroid cancer, which responded extremely well to single-agent everolimus, a near complete response. But we see the exact same thing in differentiated thyroid cancer, where we're able to give an mTOR inhibitor, and we're seeing great activity with much less side effects than we see with other drugs. So I think we're seeing more and more targets that we can hit. And I think that's one of the more exciting things about thyroid cancer going on now.
At this moment, we do not have proper molecular tests to stratify patients in terms of optimal drug treatment. We do not know what the relationship is between the molecular profile of the cancers of our patients and the optimal drugs for personalized treatment. So I expect that in coming years, we will learn a lot about molecular profiles of patients with metastasized thyroid cancer, and that profiling will help us to stratify patients for better targeted treatment, like we have seen in other types of cancer, that according to a molecular profile we choose the optimal drug. At this moment, this is not the case in thyroid cancer. It's more or less a black box still. But I expect that this will change in coming years.